Hi, thank you for watching this Fellows Conference prep presentation by myself and Dr. Kim. I will be reviewing some background information in management, and Dr. Kim will be reviewing cases at Thursday's Fellows Conference. I'm going to cover some take-home points at the beginning. I'll review cysts and characteristics in the middle, and it's okay to zone out for a portion of this because I'm going to come back and cover all the important topics again at the end. In an attempt to fulfill at least one principle of adult learning, there will be some intentional repetition to sink in core concepts. So the incidence of pancreatic cysts is increasing, and this is largely due to an increase in cross-sectional imaging, and depending on the indication and type of imaging modality, the incidence of pancreatic cysts in patients can be 2 to 19%, again depending on the patient population you're looking at. The incidence of this increases in patient subgroups such as those with von Hippel-Lindau and polycystic kidney disease, and those with a history of pancreatitis, which can develop pancreatic pseudocysts. Here's a differential for pancreatic cysts from the CATS 2008 paper. I'm going to go through some buzzwords now and help us start considering what is important and surgically relevant. This is an illustration from a radiology website, just looking at some of the more common cysts and when we start to think about malignant potential. So off the bat, I want to emphasize that serous cyst adenomas and pseudocysts have zero malignant potential and should be operatively managed based on size and symptoms, while the mucinous cystic neoplasms and intraductal papillary mucinous neoplasms have malignant potential and merit thorough evaluation and possible surgical management based on imaging and fluid analysis. Typically at this point in cyst lectures, we start going into each individual type of cyst, but I think it's important to start with this 2016 algorithm because it will help frame the remainder of the discussion. Quick note, if you're looking at other YouTube videos on pancreatic cysts, Dr. Heslin from the University of Alabama has a nice presentation on pancreatic cysts that's worth watching, and while you're going to see this algorithm presented a few times in this presentation and other presentations on the topic, I like that beyond the algorithm, Dr. Heslin started his presentation by pointing out that the challenge for the surgeon in the management of pancreatic cysts begins like any other surgical oncology problem, which is that you weigh out the biology of the disease versus the patient's comorbidities, i.e. many of these are very slow-growing lesions, so you have to ask if the patient's going to outlive their disease without operative management. And you also have to consider the technical aspects of this operation. So not so much is it resectable from a standpoint of vascular involvement like we think about in pancreatic adenocarcinoma, but it's more so extent of disease. So do you really want to perform a total pancreatectomy on a main duct IPMN patient or a patient with proximal and distal concerning pancreatic lesions? Once you have these considerations in mind, we can consider each cyst individually and go down this algorithm to safely determine management. There are a few things that will take you to the operating room early in the evaluation of pancreatic cysts, and those are, number one, symptoms such as abdominal pain, back pain, anorexia, early satiety, weight loss, and jaundice. These symptoms merit management on their own, but also are associated with an increased risk of malignancy in these lesions. Number two, there are 3 imaging characteristics that will also take you to the operating room early, and that is a main duct dilation greater than 1 centimeter, solid component to the cyst, or mural nodules in the cyst, all of which increase the risk of malignancy. There's also a few imaging characteristics that will keep you out of the operating room, i.e. if it's a small cyst without solid components and without pancreatic ductal dilation, or if you trust your radiologist and they say this looks like a microcystic serous cyst or microcystic cyst with a honeycomb appearance that is consistent with a serous cyst adenoma, you can stop there and repeat imaging in 1 year and every 2 years thereafter. If you have a larger lesion that can't be called a serous cyst adenoma because it is oligocystic or indeterminate, at this point the patient is heading towards the endoscopy suite for EUS and FNA and fluid evaluation, and the branch point here is if there's mucin and CA levels. So low mucin, low CA levels, and you can go back down the serous cyst adenoma pathway and observation. And the last thing that will keep you out of the operating room is if you can diagnose a small side branch IPMN without mural nodules and wall thickening and a non-dilated pancreatic duct and benign appearing cytology, this patient you can keep out of the operating room. And the only caveat to this portion of the algorithm is that the patient has to be willing to undergo surveillance rather than surgery. I.e., if you have a 35-year-old with a concerning cyst, they may get sick of having CAT scans or being anxious about their malignant potential for the rest of their lives. So the mucinous lesions that will take you to the operating room are lesions larger than 3 centimeters, and 3 centimeters being the magic number here. Those nodules those cysts with nodules, thickened walls, or concerning cytology or associated dilated pancreatic duct. So earlier we talked that the high-risk feature was the greater than 1 centimeter here. The number that we're looking for here in concerning mucinous cystic nodules is between 5 and 9 millimeters. And those may all end up taking you toward the operating room. The question of surveillance for asymptomatic pancreatic cysts comes up, and the AGA came out with these guidelines in 2015 for surveillance, but admittedly they're not based on very good evidence. And in brief, once you've ruled out all the scary features of these cysts that would take you to the operating room, and you've decided to have the patient undergo surveillance, the recommendation is the patient undergo repeat imaging at 1 year after the diagnosis and then every 2 years thereafter. That is for patients that don't have concerning features and that their EUS FNA was not concerning. Now, patients that you have in surveillance that have a change in size or characteristics of the cyst, i.e. they develop a mural nodule or wall thickening, this should prompt at least an EUS FNA for further consideration. Now, if the cyst remains stable over time, so you do your 1 year scan and then your every 2 year scans, the AGA recommends stopping surveillance at that point. So that's 5 years after the initial diagnosis of the cyst. This 5-year mark is relatively arbitrary, however. And we should all be aware of this recent paper published in the Annals of Surgery that suggests that about 10% of patients will cross over to resection criteria after the 5-year mark, and their incidence of cancer is higher than the general population, and that's a lifelong risk, and hence these patients should be followed long term. So while I still have your attention, let's take a look at criteria we use to differentiate concerning versus non-concerning mucinous cystic lesions of the pancreas. And these are the Sendai and Fukuoka criteria, which were recently evaluated in a pancreatic cyst database and published in the Annals of Surgical Oncology. The Sendai guidelines splits mucinous cysts into high risk and low risk, and it splits these cysts first based on symptoms, and on size, and solid nodular components, as well as main duct dilation. The Fukuoka guidelines split mucinous cysts into 3 categories, and that is the high risk, the worrisome, and the low risk. The high risk includes proximal lesions with obstructive jaundice, so again, symptoms like Sendai, and which is just a little more specific, also includes solid nodular components and a dilated pancreatic duct. But again, this dilated pancreatic duct for the high-risk ones has to be greater than 1 centimeter. Worrisome lesions are differentiated from low risk by, again, size greater than 3 centimeters, a history of pancreatitis, thickened wall, a dilated pancreatic duct, and lymphadenopathy. So when tested, just like any other test, that you can further stratify risk factors, the Fukuoka high-risk lesions are more accurate for predicting malignancy, or at least malignant potential. However, even with these more stringent criteria, we still guess wrong about 12% of the time. So 12% where we thought they had a high-risk lesion and the patients ended up going resection, we were wrong and it turned out to be benign. And for the low-risk category, of about 7% of these ended up having malignancy or malignant potential on resection. So in the next video, we're going to learn more about pancreatic cysts so that we can make more educated guesses and when determining the optimal management for pancreatic lesions.